Okay, as promised, I promised Dr. Tierney that I would start at 12:01, so here we are. Welcome everybody to this lecture, the next in our series on health, equity, race, and ethics. We called it a mini seminar series initially, but I guess you think we may keep on going. I am just thrilled to be here today to introduce Bill Tierney to give this lecture. I've got a couple things to say, both about Bill and about this lecture. First, let me just quickly and incompletely describe who Dr. Bill Tierney is. Most of you probably know him. Currently the Associate Dean for Population Health and Health Economics, and Health Outcomes at the Richard M. Fairbanks School of Public Health here at IUPUI. Before that, his most recent position was founding chair of the Department of Population Health at Dell Medical School in Austin, Texas. Maybe there's one in between there I don't know about. He was previously CEO of the Regenstrief Institute, and most importantly, out of all those positions, was division chief of general internal medicine and geriatrics here at IU School of Medicine when he hired me 17 years ago, which is the reason I had to invite him, because I owed him a favor. You know, actually, he's the one doing me a favor. And he did me a favor actually a few years ago. I'm going to embarrass him here, Bill, I'm sorry. But after I became director of the Center for Bioethics, we didn't have many speakers, and I wasn't quite sure who to ask. And I knew that Bill was coming in out of town here as he was doing his position at Dell. And I asked him to give a talk, and he agreed. And he talked about his work there. And it's a talk I've told a lot of people about. And this one will never live up to it, I guess. Maybe it's lost forever. But this is a reboot, like you're seeing reboots on Hulu and Netflix now. And he can do whatever he wants with this talk. I suspect he will. That's kind of his way. But he gave a talk about how he'd been tasked at this new medical school with improving the health of the community, which is an unusual task, as he mentioned in that talk. I don't want to steal his thunder at all. And he had really struggled with this because a med school, hires fancy people and brings them in to do grant-funded world-edge research. That doesn't change the health of the people where you're living. And in that talk, just not to preempt him in any way, he actually talked about how he overcame and planned to overcome that challenge of how do you actually make a difference in the health of your community when you're a medical school. And I found his words and his plans very inspiring. And now that he's completed that role, I'm fascinated to hear what he'll tell us today about his success or the challenges. Either one will instruct us. It's a challenge we take very seriously here. And again, it's perfect for this series, because although we talk a lot about equity and inclusion in the modern healthcare world, we don't know how to do it. And we're learning now, and as an ethics center, we want to help make it happen. And I thought of nobody better to tell us how to do this than Bill Tierney. So with that, I'm lowering expectations for you, Bill, by saying you're going to solve these enormous problems, but I'm just thrilled and thankful to have you here and looking forward to your talk. Thanks.
Thanks, Peter. I'll hopefully live up to that. I'm going to try to share my screen here, and hopefully you can see the screen with the cursor here. So Peter, I'm going to ask you, I ask people if they've got questions or comments to put them in chat, and Peter, I'll ask you to kind of keep eyes on those, and then when I'm done, we should have time at the end to start going through some of those. So, and you might want to, if there are a lot, you might want to triage them depending on the amount of time we have.
Yeah, happy to do it. Absolutely. So
I'm going to, this is really about a 25-year story that I'm going to try to boil down to about 45 minutes. So it's going to be a little bit of a whirlwind thing. I can say that I don't have any financial conflicts of interest with what you're going to hear about today. And I'm going to talk about the two towns that you would think don't have much in common. Eldoret, Kenya, the fourth largest city in Kenya, and Austin, Texas, the third largest city in Texas. Very different, you would think, but they both have similar barriers to health, that there's significant poverty in both areas with problems with healthcare access. There are transportation difficulties. I could tell you about the traffic in Austin, but it is unbelievably difficult to live there. You just can't get around because it's grown so quickly. There are child and elder care issues in both places. There are health disparities in both places, and there are multi-generational families in both places. So there's a lot more in common in some ways than you might suspect. And I'm going to first talk about Kenya. And there's this thing, you probably all heard about AMPATH. AMPATH came into existence in 2000 as the IU Kenya program's approach to dealing with the the HIV pandemic that was exploding at the time in Kenya. It's called the academic model for providing access to healthcare, and the goal was to develop local capacity for delivering high quality care, with the initial focus being on the HIV/AIDS pandemic. The main reason is that was a thing affecting the life expectancy and the health of the country at the time, despite the fact that it was only affecting 2 to 5% of the people. But it was also where the money was. That's where the U.S. government was putting money into developing healthcare systems. But 7 years into it, we made and I was involved actually a couple of years before in the IU Kenya program before they launched AMPATH. But we made a strategic decision in 2000. I guess I should say we actually, after 7 years in 2007, we surveyed the people we were serving and just saying, how are we doing? And the thing we heard is that you're doing great. We like what you're doing for HIV/AIDS, but it ain't the only problem we got here. In fact, it's not even the most important problem we have here. And so at the triennial meeting of the IU Kenya Consortium, AMPATH made a strategic decision to pivot and to begin treating chronic diseases in its HIV/AIDS clinic sites. And the idea was to leverage the tripartite academic mission so that we would do research to figure out what are the most effective and cost-effective ways of delivering healthcare with limited resources. We would then train people to build a healthcare infrastructure to be able to have the capacity for high-quality care, and then we would actually get involved in healthcare delivery. And that was the final goal: was we would leverage these academic, pointy-headed things to improve boots-on-the-ground clinical service. So the idea, and this is the motto for the AMPATH program, is that we lead with care. So you all recognize Africa, and here in East Africa is Kenya, and the western part of Kenya is where Eldoret, Kenya is, and where the AMPATH program was based. And as I said, the initial focus was on HIV and AIDS, and this is how fast that program grew. So it started off slowly because the funding was reasonably slow early on. But then as we got funding and we built capacity in collaboration with Moy University, Moy Teaching Referral Hospital. I shouldn't say capacity. They actually led these things. And the Ministry of Health. We ramped up and then with recent contract expanded to other counties within Kenya to the point where almost 300,000 patients with AIDS have been enrolled in this program. It's arguably the largest AIDS program in the world. And then there's another 500,000 patients that are receiving care at these sites for other chronic diseases like diabetes, hypertension, heart disease, lung disease, mental illness, diabetes, et cetera. So this is a picture of this is Kenya again, and Western Kenya is where AMPATH is. And then these are the initial places where AMPATH put its sites. There are now more than 500 places where they're delivering care in Western Kenya to a population of around 20 million. This is just the initial things, but it started out with these two sites at Moy Teaching Referral Hospital and Masora Rural Health Center. But after, as we got additional funding, we expanded to these two clinics at Burnt Forest and Turbo, and then these other places called Lake Victoria, Chilambo, Busia, Webuye is in here somewhere. Yeah, Webuye, Kitale, Iten, and then eventually all these other places as our capacity and our funding and our infrastructure grew. But you can imagine, you can't manage this without information. You can't manage this without knowing what the heck you're doing. So before we opened the first clinics, I sat down with Joe Mamlin and we started developing the basics of an HIV/AIDS information system. And it started out with paper and counter forms, which the clinicians helped us design. Now, these forms look ridiculously busy, but they designed them and they actually could navigate this in about 2 minutes a visit, mostly with check boxes and fill in the blanks types of things. And then so the clinicians would fill out these forms at the sites of care. And then we hired all sorts of Kenyans to hand enter these data into a database that was then used for reports, for the clinicians could access it directly looking up information. We had summaries that printed out with each visit. We We had reminders for care interventions that were due, et cetera. All on this kind of cheap paper-based system, which eventually, this started back in the early 2000s, as the technology evolved and got cheaper, et cetera, it's now been replaced by a point-of-care tablet-based electronic system that is now, it's got data now in well over 1 million patients and well over 100 million visits and over 1 billion observations. What we developed, we actually made open source, and the folks at the Regenstrief Institute did, and created a consortium called OpenMRS, which has now implemented this system around the world. And one of the things the topics I want to instill in you is this notion that the Indiana CTSI has coined, called reciprocal innovation. That means that things that on both sides of the economic divide between low and middle income countries and the rich countries, that there are things that are relevant to both, and that innovation should go in both directions. So the initial things that were done here in Indiana, this little red dot here, in developing one of the first electronic medical record systems in the world, was a platform for which the HIV/AIDS information system, and then the chronic disease management system, and eventually the generic EHR system we created, was implemented here in East Africa, and which now has come back and being implemented in the United States. So this is a way that the investments that we've made in global health have actually had local implications, and that's going to come back in the future as a feature of this little presentation. So what we found out, though, is that medical care wasn't enough. That when the first people started, when Joe Mamlin himself started seeing the first patients, and those people don't know Joe Mamlin, too bad, you should. But when he started seeing the first patients and treating with the first antiretroviral drugs in Western Kenya, they died anyway. They died anyway because they were coming and starving to death. And so Joe took money out of his pocket and fed these people. And when he did that, he realized they didn't die. And so we couldn't just pay attention to the medical care. We had to pay attention to things like food. And they had to get to the clinics. We had to worry about transportation. And we had to worry about all sorts of different things that we called paraclinical concerns. But food was the first one. And here's an example. So this gentleman's name is Musa. Musa was carried by his brother on a bicycle for, I guess, a 2.5 hour ride on a bicycle to get him to the hospital, and was literally starving to death and dying of AIDS. This is what happened to Musa 4 months later. I mean, you fed him and treated him with antiretroviral drugs. Same guy, 4 months later. So you can't do this with just drugs. We had to pay attention to his nutrition at the same time. This is Francis, came in again with pre-terminal HIV and starvation. And this is him 3 months later when he was became the director of the motor pool at the IU house in Kenya. So we couldn't not pay attention to things that would affect the outcomes of care just because they weren't drugs, devices, and tests and things like that. And so we had to develop a nutrition system and an information system that supported the nutrition system. So from the very beginning, our AIDS information system, these are actually the different forms that we had to enter data in the system for the nutrition program. So every patient that came in got an evaluation by a nutritionist. And if the patient needed nutrition supplementation, they wrote a prescription that then went to a food distribution program that would then deliver a food basket specific for that patient and the patient's entire family. Because if you feed the patient, they're going to give the food to their kids, right? They're not going to eat it. So you have to feed the whole family. And so at its height, AMPATH was feeding 30,000 people a week. And to do that, you had to have this information flow that would allow us to deliver a food basket to the health center that's nearest to their home on a weekly basis. And I won't go into that. That's a talk in and of itself. But the nutritionist could also refer the patients to other types of social support if needed, And if needed, refer the patient to this called the Family Preservation Initiative, which is an income generation program if this person was poor and had no income and needed a way of generating. Many of the people live in Kenya are subsistence farmers. And this guy, his name was Steve, I'm blocking on Steve's last name, was somewhat crazy Aussie who developed this an NGO that developed highly effective, efficient, organic farming methods for low-income countries. And we do stuff like this. This is a drip irrigation system. You know, it's not a fancy thing, but it was doable within the context of a small quarter-acre plot that somebody owned, and could grow food for their family. And it was so successful that these people couldn't eat it all. So they developed a cooperative to begin marketing this stuff to supermarkets and to other companies, et cetera, to package it, et cetera. And so we had to develop forms for that. We had to develop information for management, the microfinance loan, business assessments, agricultural assessments, et cetera. We also forms for social support groups and for orphans and vulnerable children, all sorts of stuff. It was all about information management, but it wasn't just clinical. There were more non-clinical pieces of information that we managed than in the clinical care system. One of the things that was a basic tenet of AMPATH's approach early on was that eventually the US was going to leave, that they were very generous with the PEPFAR program and treating people with HIV/AIDS and now with other associated chronic illnesses. But we knew eventually that funding was going to go away. And so we had to help develop the economic infrastructure so that people could, if it went away, they could pay for their own care. So AMPATH helped launch a clothing factory that many of our patients were employed in. There was a ceramics factory that they did a number of things. One of the things they did was build this. I think the whole thing cost about $5 to make, but it's a clay pot with a divider, a semi-permeable membrane in the middle, that you would add this little water purifier here, the water guard to at the top, and this would purify 5 gallons of water per day for a family. So the economic development not only developed sources of income for the patients, but it also developed things that we use within the program. That being said, for the early years, this all took place within the confines of the health system. So this is actually a picture of the Masoriot Rural Health Center. And it's very typical cinder blocks, people sitting on benches waiting for care. But this is a tough place to get to, right? These are roads in Kenya. And you can imagine, if you think you have difficulties in Indianapolis or in Austin, Texas, et cetera, getting to clinic, imagine if you've got 4 kids and these are the roads you've got to go over to get to clinic. There are a lot of barriers to care. And so we had problems with loss to follow-up, but it wasn't they were lost, it's just that they were unable to get in. So therefore, one of our early investigators, so if we're gonna solve this problem, we have to get outside the health center. But that can't be us. That couldn't be us, the healthcare providers, whether they're the Kenyans or the Americans working side by side. It had to be in collaboration with the community. So it had to involve community elders. It had to involve the clinicians working in the health centers. And it involved a number of community health workers to be able to reach out into the community. One of our early investigators, Carol Wools-Kalustian, who's now the director of research for the IU AMPATH program, did a randomized controlled trial. I mean, one of the problems we ran into is not only were people having trouble getting in, but the health centers were packed. The number of spaces, number of visit capability of these health centers was being maxed out. So she did a randomized controlled trial, randomizing by village of, instead of patients coming, the control condition was patients had to come in every month because PEPFAR required a monthly visit to hand out just a month worth of drugs as they worried that patients were going to sell them. And I don't know whether that was a reasonable worry or not, but that was the rule. So the patient had to be seen every month. So half of the villages, the patients had to come to the clinic every month. For the other half, a community health worker went to their homes with a, this doesn't show the basket, but with a basket that had a electronic blood pressure cuff, an electronic thermometer, an oximeter, and a scale, and would measure those things, ask some questions, and that information would all go into essentially an Android phone. And then the phone would using an algorithm would either say patient's doing fine, hand the patient these drugs this day, and the community health worker would give a month's supply of that patient's drugs, or it would say call the clinic because the patient's not doing well, and then would consult with the provider at the clinic and either do what the provider said or arrange transportation to the clinic. So the patients in the intervention group were seen once every 4 months rather than once a month, and what they found was that the care was, if anything, slightly better for the intervention group than the control group, but it essentially tripled the capacity of the health center to see patients, simply by putting, and these community health workers were our patients who had no medical training, who we just trained to do these very specific tasks. So being able to take the care to the community was actually cheaper than the alternative, which is people coming into the clinic and being seen on a monthly basis. But as you know, HIV or AIDS is a condition whereby you have the disease for up to a decade before you get symptomatic. And you can't ever break the back of the AIDS pandemic by waiting for them to come to you. Because by the time they come to you, they've infected all the other people they're ever going to infect. And so if you want to be able to break the back of the AIDS pandemic, you had to get outside the health centers and you had to start screening people in their homes. And so AMPATH then launched this thing called the Home-Based Counseling and Testing, or HCT, where community health workers and a community mobilizer, somebody from that, so the community health worker was of that tribe, but not from that community, because they're asking things that you don't want your neighbor to know as part of some of the screening. And so they were of that tribe, not that community, but somebody from that community as a mobilizer would help gain entry to the homes after initially talking to the leaders of the community and having these, they're called barazas, community meetings where they presented what they were going to be doing and got buy-in from the community, et cetera. And they went to the homes and they did a health needs assessment. They did an HIV test, a pregnancy test, a measure the blood pressure, did a finger stick a glucose test. And if any of those things were abnormal, the patient was referred to AMPATH and was given an appointment that day to come in. This program started in 2007. And by 2014, this is the 1 millionth person being interviewed. That they had, by that point, they had approached the households of 1 million people and gained information on that many people. And by 2020, 2 million people, they had entered the households of 2 million people. Sorry, they had knocked on the doors of the households of 2 million people, got entrance into 98% of them, and full capture of information for that group. So, and increased the number of patients they found with undiagnosed HIV by more than 50,000. So, what we said is, we can do that in Kenya. Why can't we do it in Austin, Texas? No. Well, are there barriers to care, or we can translate these lessons? So this is Central Texas. So this is a picture of Texas, and they call this Central Texas, although Central Texas is geographically kind of here, Austin, and these 5 counties make up the 5 counties of Central Texas. And they've been rapidly growing. Texas is the second or third most rapidly growing city in the country, and 5 of the top 10 are in Texas. Currently, there are around 2.5 million people in the Austin metropolitan statistical area. And if you know anything about Austin, it's a booming city. You know, it's a wealthy city. There's a lot of tech moving there. There are a lot of companies moving there. Tesla is opening up a factory in the southeast corner of Austin near the airport that's going to have 20,000 people working there. It's moving its national headquarters there. Google has one of its regional headquarters there and is building a building for 5,000 people to work right here. And just for laughs, I live right there. That's my apartment. So, and I still work there. I'm still a part-time employee of the Dell Medical School. So what do they need? I mean, what's the deal here? Well, the deal is that Austin is the third most segregated city in the country. And it didn't happen randomly. In 1928, the city fathers had a problem. And I'm going to read this. It says, there's been considerable talk in Austin in regard to the race segregation problem. This problem cannot be solved legally under any zoning law known to us at present. Negroes are present in small numbers in practically all sections, excepting the area just east of East Avenue. The solution of the race segregation problem will be the recommendation of this district as a Negro district. This will eliminate the necessity of duplication of white and black schools, white and black parks, and other duplicate facilities. Since the whites and blacks could never go to the same school, if they were all over the place, you'd have two schools and two everythings everywhere. So move them all east of East Street. And it was successful. 12 years later, this is what Austin looked like. Every blue dot is a white household. Every purple dot is a black household. And this is East Street. So they had a segregated city. And they have it to this, I'll get to that. We'll get back to that in a second. So Austin is the third most economically segregated city in the country because of their large health inequities, there are large disparities in health outcomes. And I'm going to show you. So this is the white area is about a third or less density, and the dark blue areas are of 75% or greater. And so this is where the greatest concentration of the whites live. These are the blacks. These are the Latinos. And this is East Street, now called I-35. So I-35 very nicely separates a city into high and low income and minority majority. These are families in poverty. The dark orange is high levels of poverty. The lighter orange are moderate levels of poverty. And here's I-35. So, they very, very successfully divided this city into haves and have-nots. And as you might guess, here's life expectancy. So the average life difference between here and here, this is about 77 years. This is about 62 years. It's 15 years, 3 miles apart. Now, you know this. You think about the zip code and genetic and stuff like that. And this is why. This is the area deprivation index for Austin. And it's not drawn in here, but you can see where I-35 goes, right? So, and the area deprivation index looks at 17 different things having to do with education, employing, housing, things from the census data and the American Community Service data that the CDC maintains. And so, I'm sorry, didn't mean to do that. So as a result, you have these areas that are high poverty and areas of low poverty. Okay, so as a medical school, we took it upon ourselves to say, we're going to do something about this. But you can't eat the whole elephant at once, right? You can't possibly do this at once. So we said, we're going to pick a neighborhood and we're going to see what we can do in that neighborhood and then show what we can do in that neighborhood. And then if we're successful doing that, try to convince the other similar neighborhoods to adopt the model that we're trying to implement. And so we picked this neighborhood. The neighborhood is called Rundberg. And this is what it looks like from a satellite. And we picked it for one reason, because it was multi-ethnic, but it also had recently had $1 million grant that had ended, that had created this committee called Restore Rundberg. So they had a very well-organized community group that was representative of the community that was committed to improving the community, but looking for a partner to help them do it. And so we agreed to be that partner. And so this again is a map of Runberg, and it's got 3 elementary schools, I guess 1, 2, 3, 4 elementary schools, a middle school, and a high school. And we partnered with a network of federally qualified health centers that is serving this area, that has a total population of just under 50. Sorry?
That's what it is. So if I'm on the phone, I can talk to everything. I can text.
You might want to mute when you're not talking. Okay. So there are about 50,000 people who live in Runberg, in about 15,000 households. The employment rate is low, but the unemployment rate in Austin is under 2%. The median age is young, and it's growing slower than the rest of Austin. The rest of Austin increased about twice this amount in this 7-year period of time. The average household is reasonably small. The median home value is $141,000 compared to the median for the rest of Austin, which is $580,000. You don't want to live there. The median household income is $32,000, which is about a third of the average in Austin. And most of the people have less than a high school education. And a quarter of the households have income below the federal poverty limit. We partnered with a network of federally qualified health centers called Lone Star Circle of Care, and they bought an existing non-FQHC clinic in this area and converted it into an FQHC called the Collinfield Clinic. And this is the clinic. And we hired a young med-peds physician named Brandon Altillo, who had just graduated from a fellowship program in Hopkins. And we brought him in to be the medical director of this clinic and lead this initiative that we were implementing with that clinic as an anchor institution for health in the Runberg community. And we created this thing we call the Neighborhood Health Initiative, which has 3 components. One being this household level assessments, which I named OLA. And that's the only cute acronym I've ever come up with, so I hope you appreciate it. But where we also implement a community-centered health home model of care. And then I'll describe this later, a community-driven health promotion initiative. So I'm going to talk about these things one by one. But we began with OLA, which is you can't meet people's needs if you can't know what they are, okay? And when you start a new medical school, who do you hire? You hire people who've been successful at other medical schools. So most of them look like me, and most of them weren't, and none of them were from Austin. So for us to wade in there and think we've got solution to their problem is just arrogance beyond understanding. And so with humility, you've got to essentially ask, what are the problems? And this is really based on what happened in Kenya, this program they called FLITTER, find, link, treat, and retain in care. So with this as a notion, we developed this thing called HOLA, where we met with the community leaders first. So through Restore Runberg and elsewhere in the community. So just to get buy-in, that they would partner with us in this activity. We also met with the residents in the community in multiple focus groups so we can generate some level of trust with both the leaders and with the residents. And then we did some key informant interviews to just say, tell us how to approach the households. Tell us what to ask and tell us what not to ask. For example, they said, don't look on our refrigerators. Don't look in our medicine cabinets. Don't ask about those things, even though those are exactly the things we wanted to know. They told us you don't do that in this culture. So there were a whole bunch of things like that. So the first thing we did is we hired a couple of community health workers, both of whom were bilingual, who would go into the apartments, into the single family homes, and do these in-home interviews. And we identified 100, it was a non-random sample of 100 households that we interviewed, that these 2 young ladies interviewed. They're 91% identified as Hispanic or Latino, 85% asked to be surveyed in Spanish, 79% identified as immigrant. and the social needs are pretty high. 24% worried about paying for their rent or their mortgage. About a quarter worried about or were threatened to have the utilities shut off. A quarter were food insecure. 1 out of 9 was complaining of domestic violence, and they didn't have a whole lot of resources if they needed money. They needed a loan. So there was need there that we thought we could help meet. So how do you meet them? Well, one is through this notion called a community-centered health home, which is where the primary care organization takes responsibility not just for the patients coming in their door, but for the community in which they live. And this is really kind of, we came up with this notion. This actually came out of the Prevention Institute in Oakland, California, back a decade earlier, but it's consistent with a report that came out in 2019 from the National Academy of Medicine about integrating social care into the delivery of healthcare. That as you've seen, I've got another whole talk on this, but the as you know, the social drivers of health affect 5 times as much of the health outcomes as do what happens within the walls of hospitals and clinics. And so if you really want to make your patients healthier, you can't ignore the things that happen outside the walls of your practice. And so the primary care health home has a multidisciplinary primary care team of physicians, advanced practice nurses and physician assistants, other clinicians, nurses, pharmacists, dietitians, social workers, financial officers, et cetera, and the 2 community health workers that we hired, who would implement the OLA in patients' homes, who would do follow-up clinic visits in patients' homes, and would be the first contact for that household and navigate if they came up with a healthcare problem that needed navigation. Don't go to the emergency room. Don't call the ambulance unless somebody is really an extremist. Call your community health worker, and she will help you get the care that you need in a timely manner. There was medical assessment within the clinic for chronic conditions, risk factors, things we usually do in primary care. And they provided the care and the follow-up and referred to specialty care as needed for co-management. So the regular stuff that primary care clinics do. But also there was a social needs assessment called the Prepare Survey, which was been embraced by the FQHC networks in the country. And where there were issues that were raised on that survey that is administered every year to the patients, then the referral to the appropriate care agency is needed. Now, normally, and back when I was practicing primary care in Indianapolis, if we came up with somebody with a social care problem, we just said, call somebody. We didn't take it upon ourselves to meet that need. In this clinic, so these things on the left side are the other than immigration issues, are the things that the Prepare survey will highlight. And so all these things on the right, other than the clinic financial officer, those are all community organizations that we had established formal relationships with so that we could refer our patients to them. And at the same time, we have developed and implemented a social health information platform that allows us to send a referral to these people and get information back that can go into the electronic health record. So in other words, we're treating these organizations as the same way that I treat a neurology clinic. Because my patient has a health need, I'm going to get it met. And if it happens to have to go to the Latino Healthcare Forum, and that's where the patient's going to go. And we have to be able to manage that the same way. We have to embrace that in the same way. So the other thing we did is that, who knows best what the issues are that need fixing and how to fix them? And it ain't us. It ain't people sitting in the FQHC, right? It ain't people sitting in the university. It's people who have lived experience. And so we asked them. So we launched this thing called community driven initiatives, where once every 9 months we'd put out a call for ideas. And this would go out on paper, electronically, we'd advertise, we'd put up, not billboards, but announcements in places like that, where people could either send us something on paper, electronically, or even just call it in. and they'd have 300 words to say what the problem is and 500 words to say what the solution was. And then those things were vetted by a panel of academics and residents. And I'll tell you why academics are in a second. Well, right now. So, and then the most promising ideas we move forward. So we had people who had helped develop the idea into a formal protocol. And if necessary, and it usually was, we get IRB approval because we wanted to aggressively measure what we were finding. We help with the training and development of the intervention and the deployment of the intervention. And if necessary, we'd fund it with up to $15,000 worth of funding from a grant that we'd gotten. We would help assess the impact, costs, and feasibility. And this is information when we tried to partner every implemented idea with a faculty member who could not only bring students, et cetera, in there and use it as an opportunity for teaching, but also then take the information from these initial deployments, and that would be the preliminary study for a larger grant to try to take this to a larger scale if it wasn't ready for prime time. And the things that were ready to be scaled up, then we would take some responsibility to seek partner institutions or organizations to scale things up. Okay. This is an article that was published in, last year in the Journal of Community Health, where we actually described the first 3 years of this program. During that period of time, we had 268 ideas that were submitted by 249 unique persons. Half of the ideas were submitted by just individuals in the community. Half were submitted by leaders of community organizations. 35% focused on social and behavioral issues affecting health. A third focused on health behaviors. 1 in 7 focused on healthcare needs. 6% focused on the physical environment. We implemented 9% of these 24, and it was limited by just the number of people and the amount of funding we had. I mean, we would love to have done more because there's some great ideas that we didn't implement, although we did help them seek additional funding or additional partners, et cetera. But we were involved in the implementation of 24 of these. 19 were completed and 5 are either in progress or have recently ended. And here are some examples. So one was simple geriatric dental care. A dentist said, we know there are a bunch of elders out there who need dental care who aren't getting it. We would like to put a chair in one of your clinics that has a bunch of geriatric patients where we could deliver free care. We have a bunch of dentists willing to deliver free care. We just don't have access to the patients. And so we developed a relationship between them and a couple of clinics, and they started delivering dental care. Another one's called Farm Share. You know, it's funny that Bastrop County is northeast of Austin and is a rural farming community, and it's a food desert because the farms take their food into Austin. They don't make it available there. They don't have a lot of supermarkets and things there. And so somebody got the smart idea, let's have a mobile food farmers market where they go to different places in Bastrop County to give the people access to healthy food. Another one is called, I'm back up on that one. So Cafe Salud was just, somebody wanted to open up a cafe in our medical school, one of our medical school buildings that would involve people from the community supplying the food, but it would be healthy food, not the crap you normally get in institutional cafeterias. This is an interesting one where these two women had this indigenous health and healing program, and they said, we don't want to be competing with your clinic at Collin Field. We want to be part of it. So the clinic was actually in a larger building. So we actually rented space for them to have an office next to our clinic, and they shared patients. That when she had patients coming to her, when they had patients coming to them who had medical issues, they would refer. And when the patients in the primary care clinic expressed an interest in indigenous healing, we refer them over to them. And there was actually a collaboration between the two. This is called Intergenerational Gardening. This is a program where we had a number of elders who had houses with backyards and would like to raise fresh fruits and vegetables in them, but didn't have the physical ability to build and to build the gardens. And so we partnered them with middle school and high school kids who then would help them build the gardens. And together they did what's called intergenerational gardening. And what we didn't anticipate is that the elders became mentors to the kids. They established long-term relationships that lasted beyond the point when the gardens were grown. And then finally, this one's called Youth Rise Texas, which is a peer support program for kids who have parents in jail or have been deported. These aren't ideas that we came up with. These are ideas that they came up with. So when we first envisioned this, we envisioned that we would start surveying the households surrounding the clinic, and then in increasing circles, we would hit more and more households until we eventually had surveyed everybody, every house, every one of the 15,000 households in the Runberg area. And then the pandemic hit, and you couldn't be knocking on people's doors and going in and surveying them, et cetera. So we had to dial back what we intended to do, and just we're doing it on patients in the clinic and doing the interviews by telephone and on the home. And that's a problem because you can't really see what's happening in the home, but it's the best we can do until Austin opens up, and they still haven't opened up. They're still in the yellow zone. So that's been disappointing. So how to sustain this? So if this works, how do we sustain it? Well, the first thing, and one of the things I want to say is that in Austin, their version of the Health and Hospital Corporation is called Central Health. It's not an integrated health system. It doesn't own an integrated health system. It's a payer, and it pays based on fee for service. And so, as you might guess, all the providers are incentivized to maximize utilization. And a lot of the stuff they're delivering is of high cost and low value. So what we want to do is to demonstrate the feasibility of this model to show that people will actually be able to do it. And these are the things that happen. So just the description of the model, and then rigorously assess the outcomes, and then provide care. Both the care was provided, patient satisfaction with the care, providers and access, emergency department visits and hospitalizations, and the cost of care and cost avoiding, or maybe in cost savings of the program. Okay. And if it cost neutral cost savings, then advocate Central Health for capitation of the FQHCs who want to implement this model, so that they can recoup the savings that happen at the hospital and emergency department level. And with the notion then it might spread to other FQHCs and be maybe even a model for primary care in high resource areas. So finally, is there applicability for this thing in Central Indiana? And my answer is somewhere between yes and hell yes. Okay, so the first thing is Eskenazi Health is an integrated health system. It starts with the FQHCs, goes all the way up through nursing homes, right? It covers the entire gamut. And so an investment in prevention can reap financial benefits, and the system can then invest those back into improving the health of the population. Eskenazi is already focused on the social barriers to health. This article was published in 2018, it's now 4 years old, and talks about 11-year experience of implementing what they call wraparound services, which are essentially social interventions beyond the regular healthcare interventions. And what they found was on an average of a savings of $1.4 million a year in hospitalization costs. So they're already kind of doing this stuff. They're already engaging the community. Each one of their FQHCs has a community advisory board that's engaged with Eskenazi, and they're increasingly using more community health workers. So they are ripe for adopting the going out beyond the health center through household level assessments and implementing calls for ideas in the communities that each one of these, the 9 Eskenazi FQHCs serve. So, so then they can take responsibility for their neighborhoods. And these are the 50 FQHCs in Indianapolis, in Marion County, that aren't Eskenazi. And the majority are HealthNet and Shalom Healthcare, but there are a ton of these out there. So if they each take some responsibility for their neighborhoods, guess what? The neighborhoods are going to improve. So the final thoughts. Health inequities are expensive. We pay for these things. Prevention should increase health and decrease costs. Healthcare should meet medical and social needs. We should take responsibility for the health of a population. And that, I'm not just talking about the FKGs, I'm talking about us, pointy-headed academics. This is an article that came out in Academic Medicine, which is the journal for the Association of American of Academic Medical Centers. And what it said was, this perspective proposes a new framework for academic health centers to expand on their traditional tripartite mission of education, research, and clinical care, to include explicitly a fourth mission of social accountability. Through this fourth mission, comprehensive community engagement can be undertaken, addressing social determinants of health and measuring the health impact of interventions by using deliberate structure and process yielding defined outcomes. And we did that at Dell Medical School. We actually have a fourth mission that you can get promoted under, right? One of our faculty just got promoted, and his area of focus was community impact. Hopefully more medical schools will and universities will take this to heart. IUPOI actually does. Don't wait for people to come to you in the clinic. Go out there and find out where the needs are and what the ideas are for meeting them. Engage the people you serve in agencies and nonprofits that serve them, identify and meet their needs. We can't do it alone. We're not big enough to do it alone. But there are already agencies out there who want to partner with us. We just have to do it. And then finally, be humble and listen. If you think you have the answers, you know what the problems are and you have the answers, you're part of the problem. And with that, I'll shut up and answer questions. Thanks.
Bill, okay, just as I hoped. It's a great talk. We have 2 questions in chat. I'm going to line them up with the easier one first, because David's asking you an easy question, which is, of course, I'm just setting you up for a fall. But then we'll get to some deeper and broader question from Jill Connors, Dr. Connors. Go ahead, David.
Thank you for your talk. Very interesting. Could you describe how the clinics, the team created relationships with the social care agencies? Because so much of the time people are given these kinds of passive resources like a website or here's someone you could go see, but how did you actually create sort of active relationships so that people in care were able to connect with these resource providers?
We went to them. We went to their offices and sat down with them and just said, how can we work together? And we didn't bring them to us. We went to them. This whole thing, it's very interesting power dynamics. In academic medical centers, we keep expecting people to come to us. And we didn't do that. Whenever we met with people, it was always in the community. It was either at a library or a restaurant or a bodega or something, whatever. We would meet people in the communities. And so we went to the nonprofits and to the city agencies, et cetera, and sat down with them and just saying, how do we do this? We need to form a relationship. Who do we talk to? Let's get our lawyers involved, and it took 3 years. It didn't happen spontaneously. But we had a commitment from the medical school that actually supported our salaries to go out and be doing this stuff. I hired a person in my department who was the director of community engagement. And it was her responsibility to follow up on all the little contacts we made, make sure that the balls stayed in the air and kept rolling, et cetera. And we actually implemented Salesforce as a customer resource management infrastructure so we can manage all of this stuff. But it's just that you go out and meet them and partner with them and don't just have a repeated number of first meetings. Move it forward. It's just say, then how does this clinic involve with these people involve your place at this location? How do we get there? Oh, gee, you have a paper ledger. We got to get you a computer so that you can connect to our system. We can send you referrals. You can send information. All that stuff had to be done, and we had a dozen people on our side working on this stuff. We had informaticists, we had social workers, we also have people from multiple schools. So my department had people join appointments in social work and in nutrition and in nursing and in even architecture in their urban development group, et cetera. We brought those people in to help us where needed to help us establish the kinds of relationships we need to establish. But it took a lot of just considered effort in saying, this is the primary reason we're here. Well, I have a division in my department in Austin called Community Engagement and Health Equity. A whole division is focused on that. It's the largest division in my department.
So I'll just brag on Dr. Craig for a second here. David's doing that kind of day-to-day engaged work that you're describing, Bill. So I think it's really two great.
So you get it. You get it. It's all shoe leather work. You know, it's
shoe leather work and person-to-person stuff. So I'm going to let Dr. Connors, Jill Connors, go from the Department of Surgery.
Hey, Dr. Tierney. And again, you know, I appreciate all of these efforts and work. This is really tough work to do. You know, and I actually lived in Memphis for 15 years, which I was expecting to be the first or the second city above, but actually it's Detroit and Newark, where there's Campton Coalition and other people doing this work. But it's also can be very heartbreaking because all these efforts are put forth. And there's just never seems to be sustainability. And I don't know, but the FQHCs in Memphis were way over capacity. We couldn't expect them to drive a lot of this work with everything they had on their plates. So, you know, my question is until, you know, well, it's two parts really, you know, how do we take those things that we know work, have been demonstrated in Kenya and implement them in a place where there's such income inequality between the have and have nots and the mentality, you know, and I've been on the whole Berwick train and everything, but there's no, I don't know, there's no sense of common goods as much. And, you know, I think until we start actually valuing and treating people as equals that live in these neighborhoods. I mean, if you ask people in the neighborhoods, you know, they haven't changed in decades. So what's it going to take to implement and make these things that we know work?
Yeah, that's a really good question, and I'm reminded of something that President Kennedy said. We don't do this because it's easy. We do it because it's hard, right? If it were easy, somebody would have already done it. No, this stuff is hard. And the first thing is to get rid of fee-for-service. As long as fee-for-service is not going to work. And that's why it does work at Eskenazi. I mean, it works at Eskenazi because 85-90% of their care is capitated. And so they can afford to, like when I first started working at Wishard Hospital, it was a 540 bed hospital. And by the time they closed it, it was a 320 bed hospital. And it was because they had shifted so much of the care in other places by investing outside of the hospital that they closed whole wings of the hospital. And so if it were not an integrated system, they would have tried to fill those beds. And so the first thing is that and I think we should just focus initially on the people who need it most, or the people who are under-resourced, is that their care ought to be capitated, period. The VA does this. The VA is a globally capitated system. They can invest in different areas outside of their hospitals, and they do. So the first thing is we have to advocate for changes, especially in places like Health and Hospital Corporation and Central Health in Texas, to capitate their care. And then we have to make sure that the people who can get a capitated payment can have models of care about how to invest that so you get a return on investment. And I showed with what Eskenazi is doing just in their clinics, they've gotten a return on investment, of $1.4 million. They're making money on top of what it costs to implement the system. So money is really not the issue, it's how it's spent. So if we can blow up fee-for-service, then we can afford to invest in things that really have high value to the people whom we're serving. So that's the first thing. And the second thing is that it's going to be a long-term slog. It's not going to happen overnight. So we have to expect small wins and not major revolutions, because this is going to be an incremental change. I think if for example, if in Austin, if Central Health was able to buy the county hospital and buy the FQHC network, et cetera, and make it an integrated health system, et cetera, then that would be a sea change. But other than something major like that, we're talking about small changes, and we have to be able to continue pushing to improve a system in small increments. But with enough of us doing that, you'll see systematic change. And, you know, is this having an impact in the community? That's a great question. I don't think anybody knows anything that we do has impact. And that bothers the hell out of me, is that we ought to be measuring health and well-being in our community in a systematic way on a regular basis. And therefore, we know if what we're doing works, because we know where we're doing stuff. We can see if the health and well-being there improves. You know, the whole reason that a city county government exists is to enhance the well-being of the people who live there. And if you ain't measuring it, you can't possibly be doing an effective job. So I would argue that one thing we should advocate for is measuring, and there's actually is a health and well-being index that the city of Santa Monica implemented, and then they tied every dollar in their budget to moving at least one of the 8 scales in there positively. And so we should be doing something, you know, should be advocating to do something like that. It would cost a couple of $1 million a year to do that. But they're investing, what was it, $1.2 billion is the budget for Indianapolis, Marion County. Then if you should be investing 0.1% of that into measuring what the hell you're doing. You know, and if we did that, then we'd know whether or not we're doing good with these things. So I think measurement is really key to this that we need to be advocating for. And that's possible. There are measures out there that could be implemented tomorrow. We could convince somebody to spend a tiny bit of money on it.
Okay, great. Again, Bill, thank you so much for the talk. We've framed our HERE series as introducing different frameworks for ethics as we think about diversity, equity, and inclusion. I'm going to think your equity today. Your framework you introduced today was public health and also global health as a framing mechanism for thinking about how to make progress here. And thank you so much, Jill, for your question too, and everybody for their attendance. And we'll have our next talk coming up in a couple of months. And again, Bill, thanks so much for doing this talk. I will tell you my other secret reason for this was that your last talk wasn't recorded. And so when I told people about it, I couldn't send them a link, but now I can send them a link, or they'll just tell them to. Now that you're back in Indy, at least part-time, I can have them talk to you directly too.
Okay, well, my pleasure. I hope to participate in more of these.
Great.
As an audience member.
Thank you, everybody. Take care. Thank you.